Good afternoon, everyone. Thank you, organizing committee, for inviting me to this topic. So my topic is on selection of first-line therapy in ALK rearranged non-small cell lung cancer. Majority of this topic has been covered in the previous ALK panel discussion. So to start with, lung cancer is the 7th most prevalent cancer in the world, and more than 50% of the patients who had light former or never smokers will have oncogenic driver, most common being EGFR followed by ALK. So its frequency in 2 to 5% in all patients, 33% in EGFR negative never smokers, most common in young never smokers, adenocarcinoma histology, in predominantly who has signet ring morphology. Clinical presentation present with effusions, 30% of the patients will have brain mets at presentation. There are 28 different EML4 ALK fusions. The clinical significance of each variant is still unknown. So coming to the ALK inhibitors, we had three generation of ALK inhibitors. So as we move from first generation to third generation, there is increased potency against ALK, broader coverage of ALK mutations, and improved CNS penetration. So coming to the first line treatment options, we had three generations of ALK inhibitors. So we'll quickly go to the important trials leading to this approval. So crizotinib is first in class, first generation ALK inhibitor. Initially it was designed to target MET, and eventually it was found to have activity against ALK. So coming to the first line treatment, this is a profile 1014 study which evaluated crizotinib versus pemetrexed and cisplatin or carboplatin. So the primary endpoint was progression-free survival. Secondary endpoints are overall response rate, overall survival, and safety. So as we can see, there is an improvement in objective response rate, 74% versus 45% with chemotherapy, and there is improvement in median duration of response. Coming to the final progression-free survival, there is absolute 3.9 months improvement in progression-free survival with a hazard ratio of 0.45, and all subgroups benefited with crizotinib compared to chemotherapy. And the final overall survivals at 4 years, 56% of the patients are alive in crizotinib, and patients who received subsequent ALK inhibitors after crizotinib had long median overall survival as expected. And we had an Asian profile 1029, which has Japanese patient, which also showed a similar results, improvement in progression-free survival by 4.3 months. So this profile 1014 and 1029 led to the approval of crizotinib in first-line setting over chemotherapy. Coming to the second generation ALK inhibitor, ceritinib, this ASCENT-4 trial, which randomized phase 3 study comparing ceritinib with chemotherapy. So ceritinib was used at 750 milligram once a day versus pemetrexed and platinum compound. So coming to the final progression-free survival, there is a doubling of progression-free survival, 8.1 months versus 16.6 months with a hazard ratio of 0.55. And in subgroup analysis, patient who doesn't have brain mets has more benefit, 16.8 months progression-free survival versus 7.2 months. In patients who has brain mets as presentation, the progression-free survival is 16.6 months versus 8.8 months. Sorry. Coming to the intracranial responses, so 46% intracranial responses with ceritinib versus 21% with chemotherapy, and duration of intracranial response also is more with ceritinib compared with chemotherapy. So coming to the with final conclusion, ceritinib is more potent, but most of the patients will have need some dose interruption reduction because of GI toxicity. And coming to this was a cross-trial comparison. So ceritinib has better progression-free survival compared with crizotinib. And coming to the second generation other ALK inhibitors, alectinib. So alectinib was initially tested in post-crizotinib resistant patients. This is from the two phase 2 pooled analysis, which showed an overall response rates of 51%, and it has better CNS response rate and CNS duration of response. Patient who received prior radiation or who doesn't receive has a similar benefit. So it had a wide coverage over different ALK mutations. So based on this efficacy, alectinib was tried in ALEX phase 3 trial, which compared alectinib 600 milligram twice a day with crizotinib. And the primary endpoint was investigated, as I said, progression-free survival. Secondary endpoints were CNS progression, response, and overall survival. Coming to the final progression-free survival, So the median progression-free survival was 34.8 months compared with 10.9 months with crizotinib with hazard ratio of 0.43. And even patients with or without CNS meds, the progression-free survivals are better with alectinib compared with crizotinib over 4 years follow-up. And this is a different second generation ALK inhibitors cross-trial comparison. So alectinib has a better progression-free survival compared with brigatinib or crizotinib. So with this data, next generation ALK inhibitors are superior to first generation inhibitors, hence it has moved into the first line standard of care. So coming to the third generation ALK inhibitors, lorlatinib. As we can see in the slide, lorlatinib is structurally different from other ALK inhibitors and is active against all ALK inhibitors, ALK mutations. So as we all know, the phase 3 CROWN study, it was phase 3 randomized trial comparing lorlatinib 100 milligram once a day with crizotinib 250 milligrams twice a day. So the primary endpoint was progression-free survival as per independent review committee, and the secondary endpoints were investigator-associated PFS, overall response rates, intracranial response, and duration of response. Coming to the overall efficacy, so as we can see, the overall response rates are better with lorlatinib compared to crizotinib, 81% versus 63%. And patient who has brain mets measurable and non-measurable, there is an improved intracranial responses, 60% versus 11%. And even the complete responses and durability of intracranial response are better with lorlatinib. As we one can see in ALEX, the complete intracranial response is 38% compared with 58% with lorlatinib. Coming to the 5-year progression-free survival, one can see after 5-year follow-up, the median progression-free survival with lorlatinib has not reached with 5-year PFS percentage of 60%. And this PFS benefits, which is exceeding 5 years, is the longest PFS reported in non-small cell lung cancer till date. Coming to the subgroup analysis, patient with brain mets or without brain mets, the progression-free survival is improved compared with crizotinib. And in both subgroups, the progression-free survival is not reached in both groups. Coming to time to intracranial progression also, lorlatinib delayed intracranial progression versus crizotinib. And one can see in the figure, after 3 years, there is no new intracranial events with lorlatinib. And lorlatinib also delayed CNS progression in patients with pre-existing brain mets, and also delayed the new onset of brain mets in patients without baseline brain metastasis. As we can see, 96% of the patients are without new development of brain mets in lorlatinib compared with only 27% in crizotinib. Coming to the dose reduction, many of the patients has dose reduction in first 16 weeks. This dose reduction doesn't impact overall progression-free survival, and this dose reduction didn't have impact on even on intracranial progression. So to summarize, lorlatinib, which offers more than 5 years progression-free survival, is the longest progression-free survival ever reported in advanced non-small cell lung cancer, and 92% of the patients remain protected from CNS progression. Coming to the side effect profile, as we move from first generation, third generation, there is increase in treatment-related adverse effects, 35% with lorlatinib, and the dose reductions has happened in 49%, and drug discontinuation has happened in 7%. However, this dose reduction doesn't doesn't have any effect on efficacy of the drug. And as we already saw in the previous lectures, the most common side effects are hypercholesterolemia, weight gain, peripheral neuropathy, and cognitive effects. So this is an overall different trials showing the progression-free survival. So to conclude, ALK positive non-small cell cancer is clinically and biologically heterogeneous and at different potency, chemistry, CNS penetration, toxicity, and cost. We lack head-to-head comparison between second and third generation data. So majority of the time we choose ALK inhibitors based on baseline patient characteristics like brain mets, availability of other concomitant mutations or variants. Thank you.